Hello everyone, welcome to this session of nutritional and endocrinal disorders in orthopedics. We have already begun this series with osteoporosis. I am providing a link of the same in the description box. Please go through the link so that you understand wear and tear of bones in a better way, and it will prove useful for you to understand this session more precisely. So without any further delay, let us begin with second in queue, Osteomalacia and Rickets. Take a keen look at this chart. Bone tissue is made up of 10% of water, 25% of organic substances and 65% of inorganic substances. 5% part of the organic substance is formed by bone cells. The other 95% of the organic substance is made up of matrix, which is formed by collagen, mucoproteins, glycoproteins, lipids, phospholipids. The main bulk of the inorganic constituents is formed largely by calcium and phosphates, and in minor amounts by other minerals like magnesium, sodium and potassium. Calcium and phosphates are present in crystalline, amorphous and ionic forms in the bone. Now let's talk about osteomalacia and rickets. The term osteomalacia means bone wasting. Wasting means a part becomes progressively weaker and abnormally thinner and softer. Osteomalacia occurs due to defective bone mineralization. It is associated with disturbances of calcium and phosphorus metabolism. The organic matrix of the bone fails to calcify properly, leaving large osteoid sims. Rickets is the clinical syndrome that results when osteomalacia occurs in growing skeleton. The disease makes its appearance at about the age of 6 months and continues for several years. These patients develop bone deformities in addition to other features of osteomalacia, and its effects may remain for the rest of the life. Now let's take a quick look at what are the conditions which will give rise to a defective bone mineralization. 4 broad categories of osteomalacia and rickets can be identified based on the underlying cause. First, deficiency of vitamin D or defects in vitamin D metabolism. Second condition, hypophosphatemia, which is often associated with renal tubule defects in absorption of phosphates. Third, drug-induced inhibition of bone mineralization. And fourth, defects of pyrophosphate metabolism. Let's consider the first factor of vitamin D deficiency or abnormalities of vitamin D metabolism. Vitamin D is fat-soluble vitamin. It functions like a hormone and its structure resembles that of a sterol. The active form of vitamin D is synthesized in the body itself, and it is called as calcitriol. In its natural form, vitamin D occurs as provitamin D2 and D3. They are inactive forms of vitamin D. Ergosterol is a provitamin which is found in food substances in negligible amounts. It is converted to ergocalciferol, that is vitamin D2, in the body. This exogenous form of vitamin D2 is not sufficient to meet our daily requirement. So, an endogenous form of vitamin D is produced in our body itself. During synthesis of cholesterol, there is formation of 7-dehydrocholesterol. This 7-dehydrocholesterol is called as provitamin D3. When skin is exposed to sunlight or certain artificial light sources, the ultraviolet radiations enter the epidermis and causes the conversion of 7-dehydrocholesterol to vitamin D3. Once vitamin D3, that is cholecalciferol, is synthesized, it is translocated from the epidermis into the circulation by the vitamin D binding protein. Similarly, ergocalciferol is absorbed in the intestine in presence of bile. Further, through the lymph, it enters the circulation bound to the plasma alpha 2 globulin. Both ergocalciferol and cholecalciferol are inactive forms of vitamin D until they are hydroxylated in the liver and kidney. In the liver, vitamin D is hydroxylated at 25th position to form 25-hydroxy vitamin D. This is done by hepatic mitochondrial and or microsomal enzymes. 25-hydroxy vitamin D is then bound by the vitamin D binding protein and transported to the kidneys. Additional stereospecific hydroxylation on either C1 or C24 occurs in the kidney to convert 25-hydroxy D into biologically active form of vitamin D, that is 1,25-dihydroxy vitamin D. Biological active form of vitamin D regulates the plasma levels of calcium and phosphates. Calcitriol acts at three different levels to maintain the calcium. 1. It acts at the level of bones. Calcitriol stimulates calcium uptake by osteoblasts, thus helping bone formation. Not to forget that bone is an important reservoir of calcium and phosphates. Also, calcitriol along with parathyroid hormone increases the mobilization of calcium and phosphates from the bone into the blood. The second action of calcitriol is upon kidneys. It decreases the excretion and enhances the reabsorption of calcium and phosphates from the kidney. Third, it acts upon the intestines, increasing the absorption of calcium and phosphates in the intestine. Besides calcium and phosphorus homeostasis, vitamin D plays an important role in regulation of immune functions, regulation of insulin secretion, control of cell proliferation, cell differentiation, growth, induction of apoptosis, and bone mineralization. Thus, rickets or osteomalacia is produced due to deficiency of vitamin D, which may arise because of malnutrition, that is diminished intake, which may also arise because of diminished absorption, especially when a patient suffers from malabsorption syndromes, gastric abnormalities, or biliary diseases. And lastly, it may simply occur because of lack of exposure to sunlight, because of which cholecalciferol is not formed and it therefore cannot get converted into calcitriol. Osteomalacia also occurs in association with inherited and acquired metabolic defects of vitamin D metabolism and function. Vitamin D resistant rickets type 1 is an inherited disorder which is caused by inactivating mutations in the renal alpha hydroxylase enzyme, rendering the enzyme unable to convert 25 hydroxy vitamin D to 125 hydroxy vitamin D, that is calcitriol. In type 2 vitamin D resistant rickets, there is unresponsiveness of the target cells to calcitriol. This occurs because of mutations in the vitamin D receptors. Renal osteodystrophy is an acquired metabolic defect. Patients with chronic renal failure cannot synthesize the active metabolite of vitamin D due to renal damage, and this causes secondary hyperthyroidism and in some cases osteomalacia. This was all about vitamin D deficiency related rickets and osteomalacia. Phosphate is also an important component of bone mineralization. Osteomalacia and rickets can occur as the result of renal phosphate wasting or loss in absence of vitamin D deficiency. Look at the following picture very carefully. Serum phosphate levels are regulated by modulation of phosphate reabsorption in the renal tubules. One of the most important regulators is the circulating phosphaturic hormone, which is called as fibroblast growth factor 23, FGF23. FGF23 enhances excretion of phosphate by kidneys. Levels of phosphaturic hormones are in turn regulated by enzyme PHEX, that is phosphate regulating endopeptidase, which degrades FGF23, and in this way levels of the phosphates are maintained in the serum. There may be inherited mutations in the FGF23 or PHEX genes, thus making PHEX enzyme incompetent to act, or FGF23 resistant to degradation by PHEX. This raises the levels of bioactive FGF23 in the circulation, and there is an increase in the phosphate excretion by kidneys with decrease in the serum phosphate levels. There are certain tumors which secrete phosphaturic substances, and such tumors also can enhance formation of active FGF23 in the circulation. We just talked about X-linked dominant rickets and oncogenic rickets. The next in queue is Fanconi syndrome. This is a familial congenital condition, and the main defect here is in the reabsorptive powers of the renal tubules for phosphates, because of which there is fall in the phosphorus levels, serum phosphorus levels. Next is renal tubular acidosis. In conditions like congenital cystic kidneys or chronic nephritis, there occurs a progressive defect in function of glomeruli and renal tubules. The kidney fails to excrete phosphates so that there is retention of phosphorus in blood. This excess phosphorus is excreted in the gut where it combines with calcium. So, blood calcium level falls, leading to systemic acidosis. Consequently, there is increased parathyroid secretion and calcium deficiency rickets results. Aluminium intoxication causes direct inhibition of mineralization. The most common scenario is patient with chronic renal failure who are undergoing dialysis and taking aluminium containing phosphate binders. Similarly, bisphosphonates are used in Paget's disease and in osteoporosis. These drugs also can lead to osteomalacia by directly inhibiting mineralization. Fluoride induced osteomalacia can result from fluoride treatment for osteoporosis or can be endemic due to high fluoride content in drinking water. Alkaline phosphatase plays an important part in construction and mineralization of bone. Hyperphosphatasia or defect in pyrophosphate metabolism is an autosomal recessive disorder in which osteomalacia occurs as the result of inactivating mutations in the alkaline phosphatase gene. The causal mutations impair alkaline phosphatase function, resulting in accumulation of pyrophosphates, subsequent inhibition of mineralization, and in adults chondrocalcinosis. Celiac rickets. In this condition, due to ingestion of wheat or gluten, the patient suffers from recurrent diarrhea and fatty stools. The basic defect is in enzyme activity of the intestinal mucosa, which probably fails to reabsorb calcium and phosphorus with ingestion of wheat. The general orthopedic defects are more or less same as infantile rickets. Take a careful look at this picture. In the first part, you can see a thoroughly mineralized bone which is well strengthened, and the pic beside it which shows a bone which is defective in mineralization and hence has become weaker. Osteomalacia in adults presents insidiously. Mild cases may be asymptomatic. Backache is the most common presentation. The patient feels fatigued with little work and talks about general malaise. Patient feels unwell and complains of general aches and pains with bony tenderness. Proximal muscle weakness is a prominent feature. The patient experiences difficulty in climbing stairs or getting out of a chair. The patient may also have a waddling gait, meaning that the patient is unable to bring bending movements to the hip and knee joint with compensatory movements of the trunk on the opposite side. The movement appears like a duck walking. Patient may have carpopedal spasm or facial twitchings and may show evidence of spontaneous fractures. In chronic osteomalacia, the pelvis becomes deformed and may make normal delivery impossible. The promontory of the sacrum comes forwards, whereas the acetibula moves inwards. So the pelvis looks triradiate. The thorax is compressed laterally. The leg bones may also be bent in untreated late cases. The X-rays may show radiolucent zones occurring at the sites of stress. They are called as loser zone or pseudofractures. Common sites for loser zone or pseudofractures are humerus, femur, ribs, scapula, and pubic rami. In children, the disease affects both cartilaginous and membranous bones. It is the growth disc which is mainly affected. Now, keenly look at this picture. The red zone in the picture shows the growth disc or plate, which is situated in between the epiphysis and the metaphysis. Taking a closer look at this growth plate, you will find that it consists of resting zone, proliferating zone, and an hypertrophic zone. Due to vitamin D deficiency, growth is retarded and so is the ossification. There is abundant cartilage but it does not get mineralized and is not converted to bone. The resting zone at the epiphyseal line becomes irregular, widened band. The hypertrophic chondrocytes are not resorbed due to defective apoptosis and unmineralized deformed osteoid tissue accumulates causing broadening of the ends of long bones. The cartilage cells accumulating at the growth plate create a depression in the soft metaphyseal end, giving rise to a cup-shaped appearance. The condition usually affects infants but may develop at any time during the period of growth. CRANIOTABES is the earliest manifestation of rickets seen in young infants. Pressure over the soft membranous bones of the skull gives the feeling of a ping pong ball being compressed and released. Crossing of the frontal and parietal bones become evident after the age of 6 months. Broadening of the ends of long bones, most prominently around wrist, knees and ankles, is seen around 6 to 9 months of age. Delayed teeth eruption is noticed in infants. Harrison's sulcus, that is, a horizontal depression along the lower part of the chest corresponding to the insertion of diaphragm, is typically seen. There is also thickening of the costochondral junction, that is, junctions between the ribs and the costal cartilages, which is known as Ricket rosary. There will be a curvature of the spine, either kyphosis or scoliosis. This, along with forward projection of the sternum, will be cause of pigeon chest. The pelvis becomes triradiate and the child's abdomen becomes protuberant, that is pot-bellied, because of marked muscular hypotonia. Visceroptosis and lumbar lordosis occurs. Deformities of long bones resulting in knock knees or bow legs is a common presentation. The patient looks sick, anemic, and has general enlargement of lymphoid tissue throughout the body along with the enlargement of spleen. Patients suspected of having osteomalacia should have a routine biochemical screen, that is, renal functions, serum calcium, serum phosphates, albumin, and alkaline phosphatase done, along with serum 25 hydroxyvitamin D and parathyroid hormone levels. A diagnosis of vitamin D deficient osteomalacia should be suspected by the presence of low normal calcium and phosphate, raised alkaline phosphatase, low 25 hydroxy D, and raised parathyroid hormone. Radiological examination is of limited use. That is, it will be useful only where pseudofractures or looser zones are present. In children, usually bone biopsy confirms the disease. The feature is increased thickness and extent of osteoid sims. Medical treatment is more important. Administration of vitamin D is quite effective in bringing about a rapid cure. 6 lakhs units of vitamin D should be administered as a single oral dose. A line of sclerosis on metaphyseal side of the growth plate can be seen on X-rays within 3 to 4 weeks after this therapy. If this is not seen in 4 weeks' time, the same dose of vitamin D should be repeated. If vitamin D administration does not show the line of sclerosis, the case should be considered as a refractory rickets. The patient should take rest till the bone becomes hard. Conservative methods of treatment also includes use of various splints and braces to correct the ricket deformities. Mermaid splints and corrective shoes are most commonly used. In case of moderate or severe deformities after 6 months of starting medical treatment, operative procedures may be required. Various osteotomies may be performed to correct bony deformities. The tibia is the most common bone which requires such operations.